Good morning and welcome from all around the world to Structural Heart Life Cases, broadcasting directly from the Mount Sinai Fuster Heart Hospital in New York City. My name is Pedro Moreno. I'm an interventional cardiologist and I will be your moderator today. Please send us your questions. We love to hear from you directly from the website or from YouTube. Today we have a very interesting session, starting with an unbelievable case and finishing with a tremendous discussion that we have prepared for you. So let me put you directly to Dr. Kinney, Dr. Kera, and Dr. Sharma at the Mount Sinai Cardiac Cath Lab.
All right. Good morning to our viewers of Structural Heart, and we actually have a little change today. Gilbert, the usual perennial surgeon, is replaced by Dr. Itagi, and Shinobu will be assisting from the surgical point of view. Rest of the team members are here, including our fellows. With
Gilbert Tang is representing Mount Sinai at EuroPCR.
Wow, EuroPCR.
He's moderating a session right now as we speak.
Otherwise, you could have been zoomed in. But the rest of the staff are the same. Let's start something new. We always try to show, and this will be showing you the case of the new valve we just introduced by the Medtronic, which is the Evolut FX Plus. So these are our the faculty with our cardiac anesthesia. Dr. Morgan and Mr. Larakis on the echo, and of course you're moderating the session. And this will be the first live case in the world of transfemoral TAVR with the novel 26mm Evolut FX Plus, and we'll show you what plus basically means. This is our episode number 59. Patient is 83-year-old with a dyspnea and angina, had a PCI in 2011, had a heart failure, CKD, COPD, and had a hip surgery, and basically on good medical therapy, and had an ejection fraction of 58% with severe paradoxical low flow, low gradient, severe AS with a velocity of 3.32 with a gradient of 44 and 24, and we'll show you that. And cath which was done, which was non-obstructive coronary with a patent mid-LED stent. So I think ECG is here, LVH with normal sinus rhythm, and this is the echo done a few days ago, and we'll have a live echo by Stem Larakas and team. Stem?
Yes, thank you, Dr. Sharma. Good morning from New York. I have with me our team, Dr. Prati, the fellow, the structural imaging fellow, and Hafizur, a great sonographer. As you can see here, normal LV function, the aortic valve leaflets are thickened, a little bit calcium, mild calcification. By CT, the calcium was 450 on this valve, mostly fibrotic. The patient is a woman, and as you can see, normal LV, normal RV, no pericardial effusion, mild aortic regurgitation. Short axis of the aortic valve, tri-leaflet aortic valve, again, thickened leaflets, mild calcification, decreased excursion of the leaflets, severe aortic stenosis from this view, again with color, mild aortic regurgitation, four-chamber view, normal LV function, normal RV function, five-chamber view, decreased excursion of the leaflets, as you can see here, mild aortic regurgitation, and we got a better gradient today. As you can see, the peak gradient is 3.9. With a maximal gradient of 62, mean gradient of 33, the velocity was 3.9. And applying everything, the aortic valve area comes down to 0.6 centimeters square, severe aortic stenosis, mostly fibrotic, mild mitral regurgitation, mild tricuspid regurgitation, no significant pulmonary hypertension, no pericardial effusion, and the IVC with full collapse. Thank you very much.
They're beautiful. Basically, in last 2 months, the echo data which I showed was almost 2 months old, and clearly things have progressed. Now it's almost no longer low flow, low gradient because your velocity is almost 4. With that note, let's go back to the presentation. So this is the case of aortic stenosis, very little aortic regurgitation. Coronary, as I said, were okay. And this is the cardiac CT analysis. Maybe Sahil want to make a point on this?
Sure. As Stam pointed out, this is a fibrotic valve, typically what we see in older females. No longer paradoxical low flow, low gradient. I think it is true severe aortic stenosis. Your AV annulus is without any calcium, Perimeter is around 70, area 374. LVOT is around the same, perimeter of 72. Next slide, please.
And the mean is about 22, yeah.
STJ has slight calcification, you can see it, but your STJ diameter is around 23.5 into 21, and your sinuses are pretty reasonable, around 29.3, 29.0. Next slide, please. And left coronary height is around 10 millimeters, sinus height is 17. RC is pretty generous at 15.2 and a sinus height of 17.
So coronary point of view, it seems to be a good protection. So not an issue with that, although many a times we do worry when the overall sinus is less than 30 and height is less than 10. But it's okay, just about there. And actually, which is a special valve which we are going to use today, is less of hopefully less coronary obstruction. So anything new on this one?
Yeah, no, I think that's very important. Dr. Sharma just pointed out that, we don't look at just the sinuses itself. You have to look at three-dimensionally the entire structure, whether it's the STJ height, the takeoff, as well as the leaflet length. So you have to take into all the factors. And I don't think this is a very high risk for coronary obstruction here.
Okay, so they actually have the chart for only Evolut. They have not updated for the Evolut FX, right? I mean, they still remain the same. The data about the same which valve to use, which is the 26 millimeter, and as you can see, we have called it a FX Plus based on the various diameters and dimensions on this particular case. And this basically Evolut FX Plus TAVR system, you can see a new hole in the TAVR valve. So this actually, I can tell you, many years ago, I actually was thinking, we actually call it, we try to get the patent on the stent, the bifurcation, that make a hole, like hole into the stent, so that has access to the bifurcation lesion. So similar kind of concept that for the coronaries, that they make a bigger hole compared to those small. Anu, you used this case yesterday. Tell us a little more about this special FX4 Plus and then various of those French sizes hole in these cases.
If we have another picture, so actually it's a large diamond.
Yeah.
Diamond-shaped axis there. You can see it. They usually have three, so you can see it. It will be one closer to, based on the way we are going to orient the valve, closer to left main, other one will be next one closer to the RCA. So our engagement will be easier. And I think we can best see it after deployment. Commissural alignment, all that should be done exactly the way we normally do and release the valve. And then you will be able to see this particular diamonds mostly in the, likely maybe in the RAO. You'll be able to see it both on for the right side as well as the left side. And we after this case, we will show how we can engage the coronaries.
Yeah, so this is basically a delivery system. So have they changed anything in the delivery system, or it remain the same way?
It's exactly the same,
same
platform.
Okay, so basically the delivery system which was already there for the Evolut FX remains there, but only is the change in the valve with FX Plus. So basically, as you can see, the hole is at least 21 to 26 French. Our catheter usually 6 French, so it's at least 4 times of the catheter size. So that expect that better engagement, and the commissural alignment still remain the same way?
Mm-hmm. Yeah.
Okay. And so we...
Commissural alignment is very important. So these diamonds will face right in front of the ostia of left main and RCA.
Good. And they say that once your commissural alignment, it's really you are able to do a favorable alignment and engagement of the coronaries. Why this? Remember, re-access study did show that self-expanding valve was one of the important predictor of inability to engage the coronaries arteries selectively. And then since then, there have been some data to show may not be that different, but we know that real life, and you take all the cases despite commissural alignment, although problem is less with a good commissural alignment, but still there is a trouble in many cases to engage the coronary selectively. So towards that, this is the new addition of Evolut FX Plus from the Medtronic to make that basically those 2 holes try to get in front of the right coronary artery and the left main. Sahil, you want to make any more comment on this FX Plus platform?
Yeah, I think it's not, most of the times you will be able to get it if you have commissural alignment in front of the coronary arteries. well, there's certain times when the takeoffs are pretty not straightforward. At least this will ensure that you can come around it. So some kind of an access, whether it's right on FOS or slightly away, should be able to achieve coronary re-access. So I am pretty excited about it. I think this is a great step, bridging durability, hemodynamics, and re-access in a single valve platform.
Okay, so let's ask Dr. Shinobu, when you're doing a surgical valve replacement, do you ever worry about the coronary obstruction at the time of the surgical valve replacement?
Sure, yes. Just same as TAVR, sometimes each patient has a little different height of takeoff the coronary. So when the coronary is coming off the lower, and then when we try to put as a surgeon, we try to put as big as valve possible. So when you try to put the big valve with the lower coronary takeoff, there's always a risk for the coronary obstruction. Also, there's sometimes a calcium around it. So it's same concept as the TAVR. We all see these factors when we do the.
Is there any surgical technique or surgical valve which is preferred if there is a low coronary height? Let's say coronary height is 5 millimeters from the aortic annulus. So is there any particular valve which you use more versus other if there's a low coronary height?
Well, I think it's just the way how we implant, and then sometimes it's not just one valve is better than the others, but I think it's more for the how you depending on the surgical technique. Sometimes you have to enlarge the root to just prevent the coronary obstructions, but it's not like one valve is better than the others, but it's more for the surgical technique, I think.
Okay. Do you ever do a reimplantation of the coronaries because they were very low?
No, we don't necessarily do that. I mean, unless we have a trouble, we know that there's a coronary obstruction, then you sometimes have to do the root replacement, but no planning to do that from the beginning. Okay. It's only when we get into trouble or. Yeah.
Okay. All right. So that's where you heard aortoiliac bifurcation. So Sahil looks all right.
It looks great. No issues at all there. Yeah.
Your primary side is left or right?
Right-sided. Yeah.
Right.
Left has a high bifurcation. We're going with the right.
Right. Okay. Aortic arch.
No issues at all. We did the Sentinel device.
The Sentinel has been placed.
Yeah.
And so summary of the case: 83-year-old patient with dyspnea. Low flow, low gradient versus high gradient aortic stenosis, predominantly AS, mild AR. Mortality risk is 8.7. Evaluated by heart team, recommended transfemoral TAVR. So transfemoral TAVR using a 26mm Evolut FX plus via the right percutaneous femoral arterial access with central cerebral protection, which has been done. Feasibility of the quick coronary angiogram will be demonstrated post-TAVR. So that is what the case will be, that after the valve deployment, but you still have to go with the commissures, right? I mean, you still have to emphasize on the commissure alignment.
Right.
And then in the end, we'll show the engagement of the individual coronaries by using a JL and JR catheter. All right. Anu, tell us what you have done so far. Go to next now. Go to our...
go live, please.
And show the hemodynamics on one side. You have to flush a little bit.
We did.
And we can show the hemodynamics below.
Small.
Yeah, good.
No, what you can do is just hemodynamics, you put on
Okay, that's
the
good.
cine, on the fluoro by the side.
Okay. So there was aortic stenosis. We had about 30mm gradient. So what wire you use and...
We used, straight Arumo to cross with AR2. We can show you that. Yeah.
So let's talk about Pedro on this particular case. That the wire has come out or you're engaging now?
No, done. This is just fluoro, I'm sure.
So question comes is pre-dilatation versus no pre-dilatation. This valve, which is not very calcified.
Yeah, I agree with you. I think this valve probably doesn't need to be pre-dilated. I totally agree. There's a significant improvement on those for many years ago that show that if you use less pre-dilations or more or less post-dilations, you may decrease the risk of a stroke. Yeah.
Okay. So
also I think pre-dilatation, when you don't have much calcium on the valve, I think it makes the leaflets more pliable. I think if you don't pre-dilate, it gives you a little bit better anchoring as you're deploying your valve. Remember, you can always post-dilate. So I don't think we need to pre-dilate here. So we're doing a standard technique,
Pigtail and then
pigtail and then your safari wire.
Yeah. Come this way.
Okay, so we
So we're going
selected
to go-
26mm, right?
Yes.
Evolut FX Plus. And we are
Which
not
is
doing
the
any
view?
pre-dilatation, I just
This
spoken.
one, that one.
So
And we are
Elio
going to
first
go back
see the
in.
hat
So
marker.
always to have your view already decided based on the CT.
Yeah.
Usually they tell us which is their implant view and the commissural view. That's what we do.
So standard two views, we do the coplanar and then we go to our cusp overlap view. Our cusp overlap view is RAO 11, caudal 17.
So what is the benefit of cusp overlap view, which a lot of people are talking about becoming the standard nowadays?
I think SS, the biggest benefit is obviously your depth of implant. In the non-coronary cusp predicts your pacemaker rate, so you can get an ideal depth of implant around 2 to 3 millimeters.
Basically, that improves the implant depth and hopefully with the less need for permanent pacemaker.
Correct.
Okay, now we have to make sure the hat marker. Can you see going on fluoro? Hold on.
So let's
Move
see
it.
a track here.
Yeah, you can see it better. 1 second. Here, let me take a cine. See, hat marker is on the other
Outer
side,
side.
outer side. Yes.
Yeah.
So based on that.
Good.
Okay, good. Let's
So
keep
flush
going.
port at 3 o'clock, hat marker on your outer side.
Yes.
Good. That's
So looks
where it
pretty
is.
good.
Now
Let's
go
go
to
to
your
our
view.
view.
Pigtail in the non.
Screen south, please.
Oh, went to LV.
The ventricle.
While we put the pigtail in the non-coronary, there is a question
Yeah.
that says that we
Yes,
had
Chair.
some differences between the gradient obtained by the Doppler versus the gradient obtained by the hemodynamics. And the question is if we think there is a malaligned Doppler cursor for Dr. Lerakis. What do you think about that?
You mean that we got a
That we got a less gradient hemodynamic and you have more gradient by echo. That's the question.
That's always the case, and not even that. That echo was done as soon as the patient came into the room, and we are now sedated.
Little more sedation. Beautiful. Yeah. So just
Better
to say,
hemodynamics.
overall, about 5 to 8 millimeter gradient always has been reported by every study. Echo, let's say your gradient of 8 on your angiogram, your echo gradient will be about 15. Your angiogram gradient is 0, echo gradient will be 7 to 8. So that has been shown by every study as well as our personal experience. And so, yeah.
that's
Okay,
correct.
so we are.
We're going to pace here. Can we
Hold
test?
on. Let me go cine.
Good.
Okay. This is very important. SS, you see that?
Good. So,
We're going.
so
So
take a look
pace
at
to
the pace.
150.
No, but 1 second. No. There's no rush here. Now show, based on those holes, how are you aligning them?
No. We don't see the, right now we do not see the diamonds. Let's keep
Okay.
it clear, diamonds.
Okay.
Large diamonds.
No, but
we don't
based
see
on
it
your
right now.
alignment, commissioner alignment now, you expect your diamond will be the left side and right side?
Yes.
Yes.
Okay.
One will be in the non and one should be in the left, one should be on the right cusp. So if we are able to deploy it first time without any issues, that's what will be. Okay.
Pace
So I'm going to 150. I'm going very slow. Watch here. This is
Give
going
me a
down.
test.
Test.
Good.
Went down.
Good.
Pull
good,
back.
Good. Go to 80. Go to 80. Good. Okay. Pace
Okay.
up 80. Thank you. Go LAO,
Right.
please. You can
So
take a
no
picture
need
here.
to test. Okay,
You can
once
take a
I will-
picture. Nice. Let's go LAO.
So we see the dot on the left. That's very clearly seen.
No, we are right now. We still don't see the diamonds clearly. We are looking at the 3 dots.
Yeah.
Make sure there are dots at the bottom You see there?
So you want to remove inflow parallax in the LAO
Yeah.
view. Looks pretty good here. We'll take a
So
picture.
there, you see the 3 dots in one line, no
Correct.
parallax of the valve. So I'm going to do another cine here. So
Fantastic.
looks very good.
So I actually like it a lot.
Depth.
I think there's not much calcium on the valve. It's okay. You have good anchor here. 3 dots are below the annulus. I think we can take it, and there's enough room to post-dilate if need be.
Now, my question here is maybe the audience, how can you be sure now that open hole of the left side, that's what we're biggest worry about, is that we're going to face the left main now?
We cannot
How
show.
confident will be?
No.
So if
It's
you
just
see all
this.
the steps, your hat marker on the outer curve, and you have 2 dots, well, which is not very reliable, but you have 2 dots on the right side of the screen. You can say you will have commissural alignment from the experience, what we've published in the past, around 96%, but you'll only find out once you fully release the valve how your commissural alignment is.
Okay, very
So
good.
your question at this time, can we reorient it and change it?
Yeah.
No.
Okay. All right.
But
I wanna
what we
do-
can show is if they can give us a valve, we can show it to the audience later.
I want
how
one more
it shows.
picture here just to confirm we are well anchored, nothing has moved.
Good.
Everyone likes it?
Very good.
Yeah. Hold the thing. Now, pigtail back. Pull the wire back a little bit. Yeah, center. Yeah.
Pace
Okay,
150.
180. 150. Okay.
Pull the wire more. Good.
Go 180. We are releasing.
Fantastic.
Okay, 150.
150.
Don't do anything. We are good. Wait, let me pull the wire back. Yeah.
Good. Push the wire down. All right. So
Clean the
looks very
pigtail.
good.
We are going
Back
to
up
use
80,
that
please.
for hemodynamic tracing.
80. Remarry the system. Back up 80. Thank you. Let's get a pigtail inside. Let's check
Okay,
some
but-
hemodynamics.
Do the aortogram first. Yeah.
Come out.
Yeah,
Wait.
let's do
one
the
second.
autogram.
Later.
Yeah. What's the
Okay.
question now,
Yeah,
Pedro?
we have another question. It is about the strategy if we have significant AI,
Yep.
if we change at all our strategy. I think the question is important because sometimes we have severe AI or moderate to severe, and the gradient that the AI can produce
Flora?
can, obscure the clarity of the valve.
Let's take a
disease.
picture.
Yeah, so that is a very good point, and that usually happens in the bioprosthetic valve degeneration. Almost half of them will have a severe AI with a little bit of aortic stenosis. But native aortic AI, the native AI is all troublesome for the tower
Fantastic.
till we get a new valve. With the Gina valve and J valve are the both. Gina valve actually is almost to the finish line. We expect that to be approved by end of the year, which is basically has those gripper clasp
Diamond.
first, and then you put a valve inside for the pure AI. But so question is 2 things. One, the AI start as a procedure. Second is we have done a BAV quickly and now created severe AI. That time you quickly go and deploy your valve.
Where?
But in the native AI, it still remain troublesome for the various valves, whether it's a supraannular or bioexpandable, the balloon expandable or self-expanding valve. So always the issue remain, and therefore we need to be a little cautious in the pure AI situation, except if it is for the degeneration of the bioprosthetic surgical valve.
Fantastic.
Yeah.
To your point, Pedro,
So you want to talk about the depth?
Let's say 1 second. Stam, you want to say something?
Yeah, I want to say because maybe you were saying that if the patient has combined native aortic stenosis and AI, I agree with what you say that the AI may affect the gradient, but if you apply the continuity equation, you will get if you have severe AS, you get the severity of the valve because the AI will take care of both parts of the equation,
Give me
both of the
diagnostic
numerator and
FN.
the denominator.
good.
The AI will affect the same way.
Gradient. Pigtail.
So you come down to the aortic valve area that will be the correct one. So the gradient may be affected a little bit, but the aortic valve area that you get by the continuity equation will be accurate. So you cannot mix it up like that. And also you see the valve, if the valve is thick and calcified, you can tell. So you have to put everything together. Yeah.
Yeah,
Okay.
we can expand on that if we have the time. The clinical diagnosis and the signs are very different between the 2 conditions. Yeah.
Yep.
Yes.
So, okay, what are you doing now?
No, we are just getting gradient and we took a picture where you can start seeing the diamonds. Go back in the aogram.
Show us, Skinny.
So if I change
Right,
the view,
no, the bigger view.
I
No,
think we
go
lost
minus.
the view. Here. Something happened with the view there, but
Yeah. Okay.
so you could see the cells very nicely, and the depth is around 3 millimeters, exactly where we wanted.
Okay, here. Can you see the diamonds there? Where the pigtail is?
Mm-hmm.
Yeah. At a 9 o'clock position, if you think about it, you see those diamonds. Yeah.
But I'm more
Large
worried want to see more around 3 o'clock or the left. Our
No.
biggest issue is
Left you will not be able to see it. Let's
I see.
engage it first, then we can try to
okay.
Let me give
show
you
the
hemodynamics
diamonds.
first.
So right now we are doing the hemodynamic measurements.
Yeah, I think the diamonds by fluoroscopy, you need a little bit of imagination.
Zero everything.
Lot of
No,
imagination.
no imagination. You see it. Ay.
I don't know where we are seeing,
you
but
go.
that's okay.
We believe
Zero
you,
everything.
Peter, we believe you.
Okay, look here. Okay, right there. You see the diamond big?
Yeah.
Yeah.
I mean,
that one, no. I think the 9 o'clock right one we can see, yes.
Yeah.
But
The
left
left
one
one
we
you
don't
can
have to.
see. Left one also. You see there?
You want to go to some different view? Or this is the only view?
Even the left
Or the
you can
okay.
see. Yeah.
The hemodynamics, you see the gradient is none. Diastolic pressure is good, about 60, 70, which was there. Now we want to show the RO for the left side.
We're good.
And
So
we got
now-
good depth. So you have
Yeah.
depth around 3 millimeters. So we nailed it. No change in rhythm.
Yeah.
And
Did we do echo? No need to post, right? Come.
stamp
After
can you
echo,
just-
then we will do the engagement. And when I start engagement, you're going to start the timer.
No, but take the
Yeah.
pigtail catheter out. No, please, or you want to leave it?
Okay,
Okay.
take it out.
Floor,
One
floor.
second, one second.
Fluoro.
Good.
Good.
Yeah, another
it there.
question, Anu, because you need to re-engage usually when you have to intervene. One of the assistants is asking to use the EBU catheter to engage the left main.
That is
No,
correct if you're planning intervention, but in this case,
Right now we
we're
just
going to
placed it.
show
Let's just show it with
engagement. Yeah.
the
So E-
floor. Yeah, FL. Our regular catheters.
Yeah, so basically what we say that whatever catheter you want to use a half size smaller. So EBU use 3.0 or 3.5, you go to 2.5 or 3.0, half size smaller. Right side catheter, whether you use Akari or Lima guide is reasonable, but we are going to just show with the JR 3.5 and JR 4.0 to engage both right and left coronary. So after the echo, show the active echo, please.
Yeah, so I think we need to post dilate.
Ah.
As you can see, can you go long axis, please?
Oh. Yeah.
All right,
That's
stamp.
Okay, please.
Yeah, that's okay. We cross with the pigtail. Pigtail will go in now.
Yeah, you see
What's
some.
my average? Can you give me the average number?
21, right?
I think we'll leave it alone.
No, why? If there's a regurgitation, no.
Is more is
22, right?
Strong,
22 true balloon. Get a 22
Get
true
me a
balloon.
22 true.
strong mild. Is strong mild to
Strong
moderate.
mild, okay.
Yeah, no. If
Yeah,
it is, you don't want to leave it.
Between 1 to 3, yeah?
Yeah.
Yeah, I think that's one of the drawbacks. You know, if you look at very old data, the biggest benefit of doing a pre, Dr. Moreno, is you prevent a post.
Yeah.
You know, so it's okay.
In this case, we had a pigtail, and we'll just go with the pigtail. Pigtail should cross like it's a normal LV, aortic valve.
Get me the.
Okay.
Hold on. To the wire.
Get me a safari wire.
And we'll use a 22 because the mean, you always have to go to the mean aortic dimensions.
No, yeah.
So both your valves are
strong mild.
with this, yeah.
Sorry.
Unless the LVOT is very calcified, it's safe to just go with mean.
Okay, this stuff. Yeah.
And also have to think about the IFU of the valve you're using.
Okay. So we are going to go with the 22 because key is in the past, or if somebody is 90-year-old, probably come out as Dr. Keeney mentioned. So, but I would say that in this particular case, nowadays we learn you want to optimize your hemodynamic as long as you are not going to increase the complication. If it's adverse calcium, LVOT, to some calcium, you worry about the rupture, aortic rupture, then you don't. But in this case, very low calcium, there is a mild PVL, you want to optimize the hemodynamics, and that's what we are going to do now. So pigtail went in, as you saw it, and then we are going to change it to now the same safari wire and use a 22 millimeter true balloon. True balloon is the one, there are a few of them, Atlas and True, not your ZMAD. ZMAD and the other Vida, Tyshak, they don't cause the expansion.
Okay.
So they're not truly non-compliant. You need to go with the true balloon, which is very good, double layer, and
balloon,
very
please.
nice to open that up. You can go to high pressure.
Good?
Yeah.
Okay.
So you also don't want to be very high with your valve. You don't want to deploy at 0 millimeters or supraannular. Then you can't do a post-dilatation. You have good room to post-dilate here. And most of our patients, we are slightly more aggressive. We make sure there's no PVL when they're leaving the room or minimal PVL, because even mild plus PVL is associated with, worse outcomes.
Now, SS, with the true balloon, we have experience that
Wait, wait 1
it may
second.
rupture, and here we just want to expand the valve. So,
right.
do you really need to do very aggressive
No,
post-dilation?
so
Okay,
no, very
180.
important.
Base
True,
180.
you cannot do aggressive post-dilatation. It
Very good.
stops. Once it inflates, it stops. You cannot, unless you
Base
put
180.
another syringe.
Let me hold
But
it.
otherwise, this is good enough. That's why we use for the
180.
fracturing. But otherwise, it just goes in, as you can see.
Sineke.
And even if Sile wants to do more, cannot do anything further.
Beautiful.
Good.
Well expanded.
Well expanded, about 6 atmosphere.
Okay, off. Okay, 1 second. Deflate.
Yeah.
Okay. We don't need to do aortogram, but we just have to
Wire out.
yeah,
Yeah.
wire out
Wire
now.
out.
Wire out. And let's get the echo team quickly,
Echo,
please.
yeah.
And get the coronaries now. JR and
Go,
JL
bro.
Come.
after that.
Stam, I don't think we're going to do anything else here.
Yeah, we have
But let him just show that eccentric, that mild PVL has disappeared.
Oh, yeah, this
Wow.
It's trivial.
trivial,
Yep,
yeah.
trivial is okay.
Minimal, yeah.
Beautiful. All right. So we are going to do the coronary engagement. Which coronary first, take it?
Left.
Left coronary first.
Minimal.
Minimum.
Need a dilator.
much
Need a
lower.
dilator.
Yep, gone. So you needed that.
Need a dilator.
So that extra push we
Would you
needed.
say, Dr. Sharma, that this day and age for PVLs
dilator.
in this
Take
type
this.
of valve, zero tolerance?
Zero tolerance. That is correct.
Give me a dilator.
There has to be a reason not to do it. That's the key. There has to be a reason not to do it, and whether that reason is basically because you are worried about the rupture and so, but otherwise,
このダイヤモンドもそういうふうにアラインされてるでしょ。
So Stam, what do you think about the echo?
Yeah, minimal.
done. Okay.
You have a
All right,
catheter
we are
too,
going
right?
with the coronary engagement now.
Okay, take it.
バイパスビートに使えないかも
Okay, finish it, so they can do the stuff, yeah. Very quickly, see subcoastal, yeah.
Okay, if we go fluoro, please, on the angio now.
Okay.
Yeah,
No,
good.
hold
Let's
on.
go.
They're
Take it
still
up.
finishing echo.
Okay,
My echo is
finish,
done.
finish, yes, finish.
Go back to the hemodynamics now. Yeah, good, very good. Okay.
Let's get some
No,
more.
no.
I want you to show
I don't want
the X-ray.
hemodynamics out. We don't need it. We're done.
Yeah. Any advice here for some questions?
Yeah.
First,
Hemodynamics out.
precautions.
No. Because what about dampening?
You have to see how we engage.
Yeah.
What dampening? Nothing dampening.
Okay.
Yeah. Okay.
Okay, yeah, so Pedro, you're saying
No
something?
problem. Any precautions during post-dilation to avoid displacement of the valve?
Yes, pace at 180 and don't move.
Don't move, yeah.
You have to wait full deflation
No,
before you
yeah,
even
he
take
doesn't
out
need-
the
no,
balloon.
no, doesn't need pacemaker.
Wait for full deflation of the balloon.
He was talking about, no,
Okay.
no, no.
Timer.
Full deflation before
Yeah.
you remove the balloon.
Yeah. Good.
Look at that.
Okay. Take the wire out and you'll show us. That's okay. Looks good.
Yeah, that looks good.
And this is what catheter was it?
4-0. I mean the JL, right?
JL 4 or 3.5?
3.5.
3.5. As I
not
said,
4-0,
you need a
3.5,
half size smaller.
3-5.
And now, maybe in some different view, you can show that big diamond. 26 millimeters should have what? 23 French hole? Or
21 French.
21 French.
Yes. So 27 French for 23, 21
Okay, ready?
French for
Yeah.
26, 29, and 35 should have 23
Engage.
French. It's in the sinus. Make it 4-8.
You are a little above.
Now we are in the diamond.
Now, my only question is you have to teach us or our audience
mean the J1?
that you are in that open cell.
Can you let's engage first.
Yeah.
No, but I know, but that is what you are teaching. How would you engage into that open cell?
No,
Should you go to different view?
I think we start with LAO view, and then if we struggle, then we switch.
You'll bring a EBU 30 also?
I don't know if I want to go with the guide in after
No,
I
what I'm
quickly
saying
placed.
is we're just trying to see.
Yeah, much better. You see
Now
that?
you're good.
So, you want to talk about the technique here?
Nothing, they saw it. I went a little bit further lower because other thing also maybe get into the LV first and then bring the catheter out, right?
Yeah.
Question for the surgeon. Any advances for high-risk
Sometime.
TAVR for
Urine.
high-risk patients with SAVR?
Go to
Any
Coronary.
advances for high-risk
Pardon?
patient with SAVR?
What was the question again? I'm sorry.
Yeah, the audience wants to know if,
Oh,
you know,
audience.
after 10 years, have you guys done any better for high-risk SAVR?
That what else can you do that for high risk SAVR? Because I know majority of those cases going for TAVR, but for some reason going
can
for
take a picture
surgery, what additional precaution or additional things you will be doing in those cases? Anything special advancement?
In case, well, the valve itself is advanced, like Inspirus, and
See if you can go to an
it's
LAO view.
designed for the future valving valve.
Ah.
Yeah, but that's probably the major advancement in the last 10 years. The valve itself is designed for the future valving valve.
Okay. And what about use of the cerebral protection during surgery to decrease the stroke rate? Remember, every trial now has shown lower stroke rate with a TAVR versus surgery, with the low risk and all of them, and with registry data. Anything else you do to decrease the incidence of stroke after surgical valve replacement?
Not device-wise.
You
I mean,
high?
we
you need to be in the middle.
scan the aorta before we cannulate and clamp. It's just a modification of surgical techniques, but
Give me
we don't
4
really
maybe,
usually
no? Right?
I agree with you, Kini.
Yeah,
let's
for
try
the
the 4.
GL 4.
Smaller.
Yeah. I think 3 was okay with the previous valve. With this one, with a big diamond, you see that?
And
We may be
post-dilated,
engaging and then it's
yeah.
coming up. Yeah. Let's see, 4.
But you can see even with the 3.5 went pretty easily into the sinus.
Okay, get me.
You guys still need to convince me.
We
That
cannot
coronary
see the
access is a little
diamond
easier.
in the left side.
We will convince you. We will convince you.
Dr. Reyes from our website is excited about this risk of displacement of the valve during post-dilation. So he's asking, should you push a little bit in while you are deflating?
No. That will
Rupture, no?
Not
You can
rupture.
rupture.
The winged balloon can move, displace the. No,
Balloon
don't do that.
should not move. Balloon
No,
should
no,
not
no.
move.
Yeah.
Absolutely. Yep.
Remember, displacement can be in either direction. It can come up or go down.
Absolutely.
Okay, now let us see. After that, our goal is to.
I think
Which
it's the
view you
takeoff of the
want to go?
coronary as
You
well.
want to show some different view?
Okay.
Now, Sahil, do you think these big diamonds reduce the radial strength? That's another
Some
question.
No. The reason it took so much time for them to design this valve is they were testing radial strength of these valves. They didn't want to compromise the radial strength. And that's why you see the cells are not uniformly big. It's only
ready?
at certain spots. See now?
Yeah, we're below.
Look at that.
No, you're still not engaged.
We are below.
Yeah.
See, we are way above. We are in the sinus.
Yeah.
And not in the coronary. You can see here.
No, we know that. But the question is, you have to say, we are way below.
We are below. We are
The
below.
question is, how, because that is part of the teaching. We are learning. Question is, this is our second valve. So we don't have to feel that we are not making a strong statement because we are learning like everybody else here.
Exactly.
And we'll come up with the strategy. So question then comes is that should you go with the guide catheter so you have the wire always inside and you can manipulate the catheter in a different direction. Use EBU 3 and leave the wire in and try to
No.
manipulate the catheter.
No. I think if we are not able to get it this time, that's okay. We have a good TAVR.
Stay there.
Okay, now.
Yeah, you believe you're in the diamond, Anu? It's very easily to cross the framework.
I have a feeling, yeah, it is in the diamond, but
So the
the
diamond
left
is a
main
little
is way
lower.
higher. Yeah, diamond is
Exactly.
lower.
Yeah,
Yeah, so
this
I
is what
think I have to go to non-diamond.
Yeah,
non.
yeah. So I think the key here is not everybody is built the same. Some left mains are higher, some left mains are lower, but this is probably for most of the patients, not for everybody.
Needs a larger diamond.
Yeah.
For
No,
your
the
wife.
question. So the question is the whole issue is that have we able to get into that regular diamond, or we have been able to go into this big diamond? So that's basically the question here is.
This is big diamond.
Yeah,
Yeah,
right.
it's very easy to cross there.
Yeah,
Suggesting is a big diamond.
So what is the big diamond is below left main. It's simple. So now
Yeah,
if you really
exactly.
want to engage, you have to go to a regular small diamond.
Yeah,
And
but
I think we
the
should not do
purpose-
that
yeah.
unnecessary. Yeah.
Exactly. The purpose of the teaching is being
Yeah.
achieved. Beautiful teaching today.
I think recrossing into the sinus was not difficult at all, and you can see
Yeah.
here also.
And we're
It's a very awkward takeoff left main.
コロナリーにさ、サクッとアクセスできないんだったらさ、意味なく
No.
ない？
Yeah.
Yeah, the audience are very engaged. So they're asking us if we should take a larger French catheter. I disagree. I think
No.
we are way below the ostium, so we should have a smaller, as Dr. Sharma pregonated from the beginning.
From there, some there.
The only question is that do you need to go with a guide catheter so that you can manipulate with a wire still and inject? So here,
Exactly,
once you pull back, you cannot inject. So anyway, let's show the RCA first.
Yes.
Then we'll see
Yeah.
what do we have on the right side. Let's show the RCA engagement. So maybe convince in one good one that RCA will be
Okay, RCA, I can show you the diamond. You
Yep.
can see the diamond in the RCA there.
No, what I'm trying to say, no, we know that. The question is, can we also do the same thing on the left side, that move our camera position, that there is an open diamond, and then you try to engage your catheter. But only question is, where the left main is coming in origin. It looks like left main is coming above the diamond, and if you need to go to the left main, you need to go above that
Exactly.
not the new diamond hole which has been created in the valve. You have to go to the regular, right, AK?
Yeah. I agree, Dr. Sharma. The other thing is that today we learn that you can always do like a test. We're doing testing through the diamond. We identify where the ostium is, and then you adapt your technique. Just don't be afraid. You know, not many people do these routinely, trying to re-engage after an Evolut valve.
Much better.
And we have done the PCI through the Evolut valves in the past, so that's not an issue at all. So regular diamonds do help.
See that?
Yeah, this is good. I think this is a non-coronary, non-dominant, very
non-dominant.
small. Yeah.
So here I'm, illustrating. You're going in that diamond and engaging it. Yeah.
Okay. Go to the left, EBU 30, please.
Fantastic.
Good. Get the guide EBU 30 with the Y connector.
There's no calcium in this valve and unnecessary that aggressive guide.
No, but
not be doing
you
it.
have it over the wire. So
It doesn't matter.
Give me the guide, please.
Okay, another question. If it is the same difficulty, why not implanting a balloon expanding valve then?
well, that's
That is for us to decide.
That's the crux of the matter.
Yeah.
That is what basically what happened. They used to have market share almost 28-30% 5 years ago, Evolut versus Sapien. But with the low risk data, and knowing that now we have an issue of the coronary access and slight difference in the pacemaker, they have decreased their market share. Like 6, 8,
That is not
10%.
controlled.
And that to regain that market share, they want to avoid at least one aspect of the coronary engagement. So that ability to FX plus. So So you are absolutely correct. The person who has asked that question, very intelligent question, you can use balloon expandable. But whole goal was that with this new advancement which have been done in this valve, does it give you any advantage of coronary access? And that was the whole question was, premise was teaching today. But again, remember, this is the second, third case in the world using this FX plus. So this is all the work in progress, like we are learning in front of our audience. And yes, after some advancement, some engagement, we will come up with some strategy, just like we have done for any other things that we tell what to do and how to do it. So this is just, we are in the process of learning at present.
His question is very simple.
Yeah.
Okay, that we are not finding difficulty in engaging.
Yeah.
So,
Yeah. No, that's what we are saying, that we are trying to teach that can you engage better with the FX plus valve. So I would say in this case, this particular case, every case is different. Yesterday they had a beautiful case. They were able to engage right away. They had like seconds, they counted few seconds on the left and right side, correct?
Yeah, no, I think that question is very valid, but let me ask you this. Why would you use a 20 sapien in a patient with low flow, low gradient aortic stenosis? If you're leaving with a mean gradient of 20 or something around that, is this doing justice? So you have to think about the patient protoplasm as well. You have to think about hemodynamics in these patients. So
I think this is just a difficult.
So, but at the same time, the counter question on that, a lot of people have said that this hemodynamic little gradient does not make any difference in the outcome up to 5 years. So maybe after, but not up to 5 years. So there are a lot of pro and cons of that point. But yes, any small annulus, and we'll discuss about the trial.
Yes.
We have few of them once we get to it.
I think you're more coaxial, although still in the sinus, you're more coaxial. You could wire from here and take it from there.
You want to
If
go
you
audio
need to
cord, or what do you want to
intervene.
do?
can do audio copy.
And that is what we wrote down in our paper also, that have a free use, liberal use of your the guide extenders, guideliner, Godzilla.
Exactly.
Put a wire and then advance your catheter. That's what we do. And so in this particular case, I would say that we are very close to sinus, and maybe you are in the very short left main.
Very short left main.
Yeah. You want to go to LO caudal, or you're okay?
Actually, you just
I think we're
counterclock
done.
in this view.
See, you are. The leaflet is being opacified as well.
Yeah.
The fixed leaflet that is
Right.
now. Yeah.
Yeah, that is correct.
No. Yeah.
So I would just, let's conclude this engagement exercise, which is good. You take this with the wire now, right? Yeah. Or you're just taking out without it?
No, the wire is there. I just disengage nicely.
So just basically,
Before we finish, give us one take-home message. Perfect valve or perfect patient for one valve, perfect patient for the other.
So I would say that there are few difference. I would say about 20% you can make 10% one selective, other 10% the different selective. So 80% they can be interchangeable. So one of the big issue what we learn is with doing a rapid pacing with the balloon expandable valve, and patient deteriorate, particularly with a low ejection fraction, and we have seen ourselves here. So therefore, in that particular case, you want to go with a valve which will require less pacemaker dependent for deployment. Even your 20 seconds of issue will be big. One. Second is the large annular and leaflet calcium, annular calcium for the rupture. So rupture, balloon expandable will cause more rupture compared to the self-expanding valve. So I think if you take those two factors together, and then of course that height of the tall frame in patient of the coronary origins, and so we all know that acute data that you have a lower the valve, the coronary obstruction with the self-expanding compared to balloon expandable, but on long run you have more difficulty to engage the coronaries with the self-expanding versus balloon expandable. So just coming back to the point, what you do, majority can be both. If somebody has a severe LV dysfunction, you will tend towards the self-expanding valve. Actually, now we are using some Navitor. So there we don't even need to pace at all. Although there is an issue about the radial strength there, but otherwise, and the low risk intermediate risk trial, we are part of it, which we have started. Second is that if a patient has too much calcium, then definitely you want to go with a self-expanding valve, not the balloon expandable.
Beautiful answer. That's a very good teaching for the audience. Hopefully that answered your question, Dr. Erades.
Good.
Oh,
So
it
let's
says excellent case.
Yeah,
Congratulations.
Can you
fantastic.
go to
Let's come to
row
our
1,
presentation
4,
for the
sorry,
today's
4
case,
to what?
which Dr. Shinobu, you want to
1,
make any
4 and
comment?
2.
And if you need to go for your surgical activity, which is completely fine, anything different?
For this case,
Yeah.
I was just wondering from the surgeon perspective, just as the origin of the coronary is different, the angle also a little different, right, for each
Right.
patient.
Yes.
Do you have any idea about that? Because this is a prefix the design, right?
Design.
So
Yeah.
do you consider that when you actually deploy the valve?
So that's a very good point. So question is, should we be taking into consideration that what is the height of the left side hole compared to the height of the coronary artery? Should you put a little down or a little above? Like in this particular case, we learned
Also
that the hole is below.
Yeah. Also the distance between the right and the
Yeah.
left. Yeah.
No, I think that's a very good question.
Right.
A very simple answer.
Right.
The deeper you go, the better reaccess is, but high risk of pacemaker, then you be higher. So we know it. We have a skirting. The holes are around 13 and 14 millimeters from the base.
Right.
We deploy at 3 millimeters, so you want to have a coronary clearance of at least 10. It
Right.
makes sense, but yes. So for
Right,
redo TAVR for coronary reaccess, you have to be a little bit deeper.
Right. Also this angle, see this is a left and right? So this distance also different, right? For
In
patient,
each patient, yes.
Yeah.
But that is hard to predict.
That's how it's
Yeah. All right. So let's go over the point now. So basically, the latest issue, what I want to talk about is the outcome in small aortic annulus. The 4 trials have been. One is the Swiss TAVR registry, which is 5-year follow-up. Then the Lighten trial of the balloon expandable versus self-expanding in the failed surgical bioprosthesis with 1-year follow-up. Then the Viva trial of TAVR versus SAVR is like 2.2-year follow-up. And in the small annulus, and the SMART trial of the self-expanding versus balloon expandable TAVR 1-year follow-up. Second is reintervention or structural valve deterioration after self-expanding TAVR versus surgical valve at 5 years data we have, particularly from CERT-AVI and other with the core valve registry. And then quality of life after TAVR versus SAVR in 5 years. So let's go through the one by one very quick. What is called as a small annulus is a 23 millimeter. Less than 23 millimeter is counted as the small annulus, which makes about 40% of our patients, out of like 35, I would say. By women, almost 45% of cases makes the small annulus. So this was the registry data comparative from the Swiss TAVI registry. They compare the patients with the self-expanding versus balloon expandable. 171 patients each arm showed one message. And that is resonate that message in subsequent presentations. That is, that you have a better aortic valve area, lower mean gradient, and very low number of cases which have residual of more than 20 in the self-expanding valve versus balloon expandable. At the same time, moderate to severe PVL, moderate to severe patient prosthetic mismatch, which is defined as less than 65 millimeters square per meter square, is higher in patients with balloon expandable compared to self-expanding. So clearly this is a message. Lower gradient, better aortic orifice, higher severe patient prosthetic mismatch. This we learned from the Swiss TAVI registry. Rest of the outcomes were not different up to 5 years. Then there was a trial of using balloon versus self-expanding in the surgical bioprosthetic small valve, less than 23 millimeter, called Lighten. And this is the same done in Canada, US, and Europe. And the message basically, start with 100 patients, some exclusion, and message came out the same way. So that you can see on the left side, the balloon expandable, which was Sapien, the side self-expanding, the valve performance. 76% with a self-expanding, balloon expandable was only 30%. So key is the overall, the outcome, no different. So Lighten trial basically showed that in valve performance was superior to self-expanding. But the overall, the outcomes were not different. So similar message, which was from the Swiss TAVI registry. Then the third, and that is our Viva trial. The Viva trial in the small annulus, 23 millimeter annulus, randomized patient to TAVR versus surgery. And you can see here up to 2.2 year follow-up, same message. TAVR Lower
on my chair.
severe patient prosthetic mismatch compared to surgery because you have a better effective orifice, and the valve area, the gradient is again better with the TAVR versus surgery. This is what we have seen in this case. Of course, the PVL and AI, which was significantly lower in the surgical group, and 2-year follow-up, individual points have been shown here. Now let's go to the next one. And that is the main study which we are waiting for. A smart trial in a small aortic annulus, randomizing patients to self-expanding or balloon expandable. I can tell you when Roxana came to me and said that she, of course, was one of the principal investigator of this trial, I said, this trial, they lost already. That this is going to be win for Medtronic. Why? Because we have immense number of data. If you go with the hemodynamics, there's no question there that at 1 year, 2 year, or 5 years, the self-expanding valve will win over the balloon expandable. So this I predicted. This is about 750 plus patients followed up to 1 year. They re-stratified based on the site and the sex overall, and they counted various kinds of prosthetic valve dysfunction. So one primary endpoint was your MACE rate at 1 year, mortality, disabling stroke, and heart failure rehospitalization. And the second was the bioprosthetic valve dysfunction, defined in 3 categories. One is the hemodynamic structural valve dysfunction, which is a gradient of more than 20. Non-structural valve dysfunction, severe patient prosthetic mismatch, which is less than 65 millimeter square per meter square, and then clinical valve dysfunction as a thrombosis, endocarditis, and aortic valve reintervention. So what did we learn? One primary endpoint, MACE rate identical, 10.6, 9.4, no different. Bioprosthetic valve dysfunction is significantly lower with a self-expanding 9.4 versus 41.6 in the bioexpandable balloon expandable valve. Pacemaker rate 12% in the self-expanding, 7.8% in the balloon expandable. Again, significant difference, almost 5% 4+% difference in favor of balloon expandable. So that was the plus point of there. Now, if you go to the individual endpoints, which are mean gradient, all similar story, which I have said so far, better valve hemodynamics with a self-expanding compared to balloon expandable, and they put it together very nicely here. The mean gradient at 12 months, effective orifice area at 12 months, hemodynamic structural valve dysfunction at 12 months, then bioprosthetic valve dysfunction in women, and moderate to severe prosthetic patient mismatch, all plus for self-expanding valve. All expected, nothing unexpected. Why? Because we have 4 other trials which have shown the same data. And pacemaker rate, you saw it 4+% higher with a self-expanding. So that's very good. Only thing is that this good hemodynamic did not translate into an outcome where he showed it at 1 year. But we know that 1 year is too small. Maybe it's a longer, but we have the data up to 5 years. In the Swiss TAVR registry, there was no difference, better hemodynamic, still there's no difference in outcome at 5 years. So now, can it be after 5 years? That need to be seen. And these are the individual endpoints with the self-expanding primary endpoint of the MACE or of the bioprosthetic dysfunction. In almost all categories were benefit of the self-expanding valve, and as a primary endpoint of the MACE, no difference in any particular group. So basically, authors concluded that among patients with a severe AS and a small aortic annulus who underwent TAVR, a self-expanding supraannular valve was non-inferior to a balloon expandable valve with respect to clinical outcomes, and was superior with respect to bioprosthetic valve dysfunction through 12 months. So this is very good news for the Medtronic, and we hope that they will have increasing share of the TAVR valve in this small aortic annulus group. Now there are 2 data which I am going to show you. That is comparison of the TAVR valve with the surgical valve. So this is actually a very nice study, structural valve deterioration after self-expanding, transcatheter, or surgical valve in the intermediate to high risk group. So what they did is they took the patient from the core valve high risk pivotal, CERT-AVI, and randomized clinical trials, and extreme risk pivotal, as well as a continued access study. So all those cases, and they have a data that the 30-day and then of course follow-up. What did they find? Up to 5 years of follow-up, mean gradient better with the self-expanding valve compared to surgery. We knew that. And same is the effective orifice area. And then the outcomes. As you can see here, that incidence of the valve deterioration is 4.38 in the structural, in the surgical group compared to 2.20 in the TAVI group. So, and the much more difference in the small annulus, much more in the women, there was no actually difference and showed. So clearly, once again, the valve, lower structural valve deterioration in the TAVI group versus surgical group. Now you say, well, it looks good, but does it translate into a re-intervention? And we actually have the data in these patients, actually similar, little bit of kind of analysis from there. The re-intervention after core valve versus surgical aortic valve replacement in the severe aortic stenosis from the same data, as you can see here. Re-intervention at 5 years with the TAVR 2.2%, with the surgery 1.5% in favor of surgery with a p-value of 0.017. You say it's a discordant. You are saying the valve degeneration is different in favor of the TAVR, but TAVI or TAVR, whatever we want to call it, but replacement is totally different in the surgery versus the TAVR. So this is what the data I'm the one to say. So I think it probably is the threshold where we intervene. I think that probably has to be the region. And you can see here now also what we learned, that whatever the intervention is done at 1 year, after that they're identical. More important, once you go to the newer generation of the core valve, which is the Evolut, the data are identical. So clearly, that once you have an Evolut valve compared to surgical valve at 5 years, no difference in the valve intervention. Yes, there is a lower structural valve deterioration as have been shown in the earlier studies. So therefore, a low incidence of re-intervention is observed for the core valve, Evolut and surgery through 5 years. Re-intervention occurred most often less than 1 year for TAVR, more than 1 year for surgery. And you do surgery re-intervention, many of these patients were for the second surgery. Why? Because this was endocarditis was the mechanism, and in the clearly the degeneration is in the TAVR group. Then most early re-intervention were with the first generation core valve and managed percutaneously. Re-intervention were more common following core valve TAVR compared with Evolut TAVR or surgery. So basically, Evolut TAVR was equal compared to the surgical valve replacement in terms of the re-intervention, but lower valve dysfunction. So this basically has put a very nice editorial from these people. Second question comes with quality of life from the TAVI cases, comparing the surgery versus TAVR. It basically looks like they're all good. Both have good improvement and last 4 to 5 years. But look at the height of the black bar. That is the no improvement or the deterioration, and of course the patients who have died. So looks like at 5 years there is some deterioration of the quality of life. Well, these were cases done by the intermediate risk, where average age was 82. So you expect that after 5 years, of course, they will go down. And this is because of the normal slowing process. The KCC score, as you can see, at 5 years are lower compared to at 1 year. To me, it is a normal, natural progression of the disease process. Patients do slow down compared to 81 years of age versus 86. So in intermediate AS patient, both transfemoral TAVR and surgery resulted in a comparable and durable health status benefit to 5 years. Further research is necessary to elucidate the mechanism for the small decline in health status noted at 5 years compared with 1 year in both groups. And I would say, I think it's very simple. 5 years later, these elderly patients are like reaching many of them to 90. So that's not uncommon. So they could not find any pinpoint region except the normal age-related decline. So beyond mortality, of course, we always have to talk about the quality of life. And there have been the data about various trials showing that, yes, 5 years, there is some decline in the quality of life parameters both with the surgery as well as with the TAVR. So coming back to the, let's complete it now. We had a great presentation. So multiple randomized clinical trials and registry data have consistently shown better hemodynamics, lower residual mean gradient, large effective orifice area, lower severe patient prosthetic mismatch in severe native or bioprosthetic AS with a small annulus after surgical, after self-expanding valve versus balloon expandable or surgical aortic valve. However, these better hemodynamics after SCV TAVR had not translated into a better clinical outcome at 1 to 5 years of follow-up. The small randomized clinical trial showed the same thing. So therefore, it needs to be seen if these better valve hemodynamics after SCV TAVR will translate into a better long-term clinical outcomes at 5 to 10 years. So this is where we need to see, and of course, long-term follow-up will provide that data. Then re-intervention after TAVR versus surgery in the intermediate risk patient has low rates of valve re-intervention up to 5 years, and similar with Evolut TAVR and surgery, and has differential mechanism after 2 strategies. There is a lower structural valve deterioration for surgery for self-expanding TAVR versus surgery in various subgroups of severe AS at 5 years. So clearly, if some person makes the claim, so I know there are some data, some more re-intervention needed in the partner 2 trial at 5 years compared to surgery, but self-expanding valve, if someone make the claim that valve deteriorate more with the TAVR versus surgery, answer that is absolutely wrong. Repeated trials have shown self-expanding valve do better than surgery in low, high risk and cases, and so up to 5 years. Then lastly, quality of life has similar benefit after 1 year, TAVR versus surgery in the randomized clinical trial, and of course they tend to decline after 4 to 5 years for unclear reason, could just be the marker of advanced aging process in my opinion. So let's go to 3 questions. Following statement is not true regarding the outcomes of self-expanding versus balloon expandable TAVR in a small aortic annulus. Lower residual mean gradient, higher aortic orifice area, lower severe patient prosthetic mismatch, lower mortality up to 1 to 5 years. The D is wrong because we are yet to see any benefit of those better hemodynamics into outcome. Then the Lighten trial at 1 year of the balloon expandable versus self-expanding in the failed small surgical prosthesis showed similar similar mortality, similar stroke rate, similar hemodynamics at 30 days, similar KCCQ score. Answer is no. Hemodynamics were better with the self-expanding versus balloon expandable. Rest of the events were identical. Lastly, following results are true about the results of the SMART trial comparing self-expanding versus balloon expandable TAVR, except lower mean gradient with self-expanding, lower severe patient prosthetic mismatch, lower pacemaker in self-expanding, and similar mortality and stroke in 2. So clearly we know pacemaker rate was higher with a self-expanding versus balloon expandable. With that note, I complete my presentation for today.
Fantastic, Dr. Sharma. Before we close, Dr. Nikhil Ha is missing Dr. Gilbert Tang and is always asking about update with bicuspids. Just one sentence, bicuspids.
Yeah, so with the appropriate bicuspid, there is still need to be a trial of the bicuspid valves. So, Notion 2 trial, which is ongoing outside, enrolling all patients, all types of bicuspid and so. Here in America, bicuspid was just the registry. Appropriate bicuspid patients were done with the TAVR, and if I take 100 patients of bicuspid aortic valve, about 40% will qualify. I'm talking about the congenital bicuspid, not the acquired bicuspid which happens in 90 years of age when we got acquired bicuspid, but true bicuspid with aortopathy. About little less than half will be good candidate for TAVR, other half will not be good candidate because of hostile anatomy and more importantly aortic dilatation. Every data have shown that once your aorta is more than 4.5, your mortality at 5 years becomes 3 times. So even if you change the valve, but aorta is 4.5 because of your better hemodynamics, probably you enlarge the aorta more. So balloon, I would say the bicuspid aortic valve, it goes with the anatomy, yes, but it's many of them have hostile anatomy and they go for surgical valve. But yes, the TAVI or TAVR can safely be done in these patients in the selected group.
Fantastic, fantastic. So having said that, I want to thank the Cath Lab team. Fantastic case, unbelievable teaching step by step. I want to remind everybody that this case, as well as the other ones, will be available for review at our website, ccclifecases.org. And most importantly, we do our structural heart cases every other month, the second week on Tuesday. So our next one will be July 9 at 9 a.m. Thank you so much.